It's time for the 3-question warm-up for Foundation 7. Let's get going. What are the characteristic features of a cell undergoing apoptosis? So you have cellular shrinkage, nuclear shrinkage, karyokinesis, which is that fragmentation of the nucleus, karyolysis, which is fading of the nucleus, apoptotic bodies, and then membrane blebing. Next question. What are some of these substances that can trigger apoptosis? So apoptosis is initiated when 1, cells are deprived of important cell signals such as growth factors. 2, if there's a lot of cell stress that's present. 3, DNA damage can be present, and that DNA repair process will fail, and that'll lead to p53 triggering apoptosis as well. 4, cytokines such as TNF can actually trigger apoptosis. And then 5, cytotoxic T cells can insert granzyme B into cells, and that's going to lead to an activation of caspases as well. Next, what are the neural crest derivatives in each of the following adult structures? So first we have the peripheral nervous system. That's going to be the autonomic nervous system, so the vagus nerve, sympathetic ganglia, the dorsal root ganglia, so those are the sensory nerves, cranial nerves, and Schwann cells. In the ear, we have the bones of the middle ear. In the eye, we have the structures of the anterior chambers, where we have the cornea, the sclera, the ciliary muscle, and the pigment cells. The adrenal gland, we have the chromaffin cells and the medulla. For the mouth, we have the odontoblasts. In the heart, we have the apical-pulmonary septum, so that's the spiral septum. In the digestive system, we have the enteric nervous system, the celiac ganglion, the enterochromaffin cells that secrete serotonin. In the thyroid, we have the parafollicular cells, so these are also known as the C cells. And in the skin, we have the melanocytes. All right, guys, so that's it for the 3-question warm-up. Let's get to that lecture.
In this video, we'll be talking about inflammation, which is one way the body responds to injury. So sometimes injured tissues undergo necrosis, which we covered in the previous video, but sometimes the body initiates an inflammatory response in an attempt to repair the damage. So inflammation is characterized by redness, swelling, warmth or heat, pain, and some loss of function. You know that. There are 2 big categories of inflammation: acute inflammation and chronic inflammation. So let's talk about acute inflammation first. Acute inflammation goes through several different stages. Now, this is number 4 in your study guide. First, you have some type of injury or insult, and that leads to the release of specific cytokines and inflammatory mediators. The specific acute phase cytokines that are associated with the inflammatory response that you need to know are IL-1, IL-6, and TNF-alpha. So make sure you know those. Associate those in your mind with inflammation. Interleukin-1, interleukin-6, and TNF-alpha. Now, these cytokines do a lot of things. They cause vasodilation and increased vascular permeability so that plasma starts to exude into the interstitium. And that causes a lot of the swelling and the redness and so on. An inflammatory fluid exudation is mediated by 3 specific chemicals: histamine, serotonin, and bradykinin. So make sure you know those also: histamine, serotonin, and bradykinin. Then eventually you're going to have fibrosis, where fibroblasts get into the tissue and start laying down extracellular material, specifically collagen. And we're going to talk about collagen in detail in Foundations 8. But for now, I want you to know that vitamin C is important in this process of fibrosis and making collagen. Then over time, that extracellular matrix needs to be degraded and remodeled into something a little more organized, something prettier. Now, the enzymes that do this remodeling are called metalloproteinases. They're called metalloproteinases because they require a metal in the enzyme, specifically zinc. So that's another substance that's vital in the healing process, zinc. You have to have vitamin C and zinc. Then there are different outcomes of the inflammatory process. Now, ideally, the normal structure and function are going to be restored. It's like the injury never happened. But sometimes you end up with granulation tissue, that beefy red, highly vascular, fibrotic healing tissue. That's sort of an intermediate stage on the way to healing, around 3 to 5 days in the wound healing process. You could also have an organized fibrotic shell that kind of walls off the inflammation from the rest of the body. And if that shell fills up with pus, we call it an abscess. Now, your body considers an abscess a success because you've segregated that area of inflammation so that the pus pocket isn't causing problems for the rest of the body. So in order to cure an abscess, you have to open it up and drain it because your body sees that as a success. It's not going to do much else with it. So you have to drain that abscess so the body can continue to heal. Then, of course, scarring occurs when, instead of healing normally, you lay down all this collagen that contracts and forms a scar, and that's going to leave some residual abnormal function. So if you have an MI and there's a scar that forms in the myocardium, that scar can't contract normally, it can't relax normally, it can't conduct the electrical depolarization normally. So scarring of the heart can lead to a variety of different types of tissue dysfunction and organ dysfunction. Now let's switch gears and talk about chronic inflammation, which causes cycles of tissue destruction and tissue repair, and then more destruction and more repair. So acute inflammation and chronic inflammation are mediated by different types of cells. Acute inflammation is mediated primarily by neutrophils. Chronic inflammation is mediated more by mononuclear cells like macrophages and lymphocytes. Those macrophages are the reason that sometimes with chronic inflammation you get granulomas. Now, granulomas are little nodules of macrophages that are found in chronically inflamed tissue. And if a bunch of these macrophages kind of fuse their plasma membranes and their cytoplasm, they become what we call giant cells or multinucleated giant cells. Now, macrophages start out as monocytes in the blood, but when they leave the blood vessel and they migrate to the inflamed tissue, we start to call them macrophages, which then surround and consume and destroy invading microbes, and they also clean up cellular debris from all that tissue injury and inflammation. But when the macrophages don't get shut down appropriately, they might keep eating away at the healthy tissue, so now they are causing local destruction. And the body has to respond to the damage that the macrophages are causing. So with chronic inflammation, you see these ongoing cycles of tissue damage and tissue repair. So how do these different types of white cells get out of the bloodstream and into the tissue? We call this process leukocyte extravasation. Now, extravasation just means the process of getting outside of the blood vessel. So you might hear about fluid extravasation sometimes. But here we're talking about leukocyte extravasation. It could be neutrophils, PMNs, or polymorphonuclear cells, or it could be other granulocytes, or it could be monocytes, or even certain types of T cells. They all use the same basic mechanism. So we're talking about neutrophils that leave the circulation and get out into the tissue. So how does that take place? Well, there are 4 steps. The first step is that the neutrophil sort of gets sticky and it starts to roll along the vascular endothelium, that inner surface of the blood vessel. So imagine that you're jumping out of a train at high speed and you sort of bounce and roll along the ground as you come to a stop. And actually this rolling process allows the endothelium to select for certain types of neutrophils that are going to pass through the endothelium. So this is the selection process, this rolling process. It's very, very important. There are proteins called selectins on the endothelial surface that are involved here. There's E-selectin, E is for endothelial cells. There's P-selectin, P is for platelets. There's also an L-selectin, which is found on leukocytes. Now, think about it. You can't have these selectins expressed on the surface of the endothelial cells all the time, or you'd be constantly extravasating neutrophils, right? I mean, you want to have some regulation and control over this process, right? So the signal that tells your endothelium to start throwing up some selectins to flag down some leukocytes are those acute phase cytokines we talked about, IL-1, IL-6, and TNF-alpha. These are going to make the endothelial cells stickier in that area so that they're selecting more neutrophils. The next step is tight binding, which involves some surface receptors called ICAM1 on the endothelial cells and another receptor called LFA1 on the leukocyte. LFA1 is part of a family of cell surface receptors called integrins, which help the cell to attach to external things such as other cells or to the extracellular matrix. You can remember that integrin helps the leukocytes integrate. Step 3 is diapedesis, where the leukocyte works its way between endothelial cells and escapes the blood vessel. So PCAM1 is the molecule involved here. PCAM1 is found on the intercellular junctions between endothelial cells, and it's also found on the neutrophils and monocytes and platelets. Then step 4 is migration, where the leukocyte travels through the interstitium to wherever it needs to go, wherever the injury or the inflammation is. These are just cells, right? They don't have any consciousness or anything. They don't know where to go. They're just sensing chemical signals that guide them to where they're needed. So these signals are called chemotactic signals, and they can be things like bacterial products. So bacteria will produce substances that have the beneficial effect of attracting neutrophils. Beneficial to us, not so much to the bacteria. There are also signals that our bodies make called neutrophil chemotactic factors, which we're going to see again in immunology. But there's C5a, which is one component of complement. There's IL-8. There's LTB4. So those are the main 3 I want you to know. And there's also kallikrein. You should also make note of a couple of other points here. This process of binding and diapedesis and migration is enhanced by platelet activating factor. Maybe it seems weird that platelet activating factor would enhance leukocyte extravasation, but it also kind of makes some sense. If you have a vascular injury, an endothelial injury, you're going to want to activate platelets to stop any bleeding, but you also need to recruit leukocytes to help get a little inflammation going and patch up the injury, right? Because again, that's the point of inflammation, to heal the injury or the insult. Then the last point I'm going to throw in here is that there's an immunodeficiency disorder called leukocyte adhesion deficiency syndrome. Now, obviously, from the name, you can tell that this is a problem related to leukocyte adhesion. Specifically, you have abnormal integrin molecules, that LFA1, which affects the tight binding step. Now, we're going to cover this again in immunology, but the classic presentation of leukocyte adhesion deficiency syndrome is delayed separation of the umbilicus in newborns. And then later, you're going to get recurrent bacterial infections. Because without normal integrins, you can't get leukocytes and macrophages out of the blood vessels and into the tissues to fight infection. Now, there are dozens of chemicals that influence inflammation, things like prostaglandins, leukotrienes, nitric oxide, thrombin, and so on. The point is, this is a very complex, tightly regulated process. We're painting a very simplified picture of it all. We're just focusing on what you're likely to see on your test. Inflammation makes blood vessels dilated and leaky. And besides leukocytes leaving the circulation and getting out into the interstitium, you're going to have fluid that also does the same thing. So extravascular fluid can be categorized as either transudate or exudate based on its composition. Transudative fluid is thin and watery. Exudative fluid is thick and it's full of stuff. One student sent in a mnemonic that the EX in exudate reminds you that the exudate has extra stuff in it. So think about transudate being mostly water. It doesn't have a lot of cells in it, doesn't have a lot of protein in it, has a low specific gravity. Transudate can be due to high hydrostatic pressure, so pressure is basically pushing serum out of the vessel into the tissue. It can also be due to decreased oncotic pressure, so if you don't have a lot of proteins in your serum, you're going to have a lot of watery transudative fluid leaking out of the blood vessels. Then, if transudate is watery, doesn't have much stuff in it, exudate is the opposite. It has lots of stuff in it. So it's rich in proteins, and it's rich in cells, specifically inflammatory cells. Exudate can be due to lymphatic obstruction, or it can be due to inflammation. And we're going to talk about transudates and exudates again when we get to ascites and cirrhosis in the GI section. Now, let's quickly talk about how inflammation might look on a larger scale from more of a bird's eye view. There are three basic forms of inflammation: serous inflammation, fibrinous inflammation, and suppurative inflammation. So serous inflammation means you have a lot of thin, watery fluid that accumulates in the tissues. Now, is that watery fluid transudate or exudate? Watery fluid is transudate. Fibrinous inflammation occurs when you have a lot of fibrinogen that gets out of those leaky vessels and it accumulates in the tissue, and it can sort of form a dense fibrin matrix in the inflamed tissue. And fibrin's a protein, right? So this would be an exudate. And then another type of cellular protein-rich exudate would be pus, which is where you have dead leukocytes and necrotic debris and liquefactive necrosis. You know what pus is. And we call this suppurative inflammation or purulent inflammation. Both of those words, suppurative and purulent, they both mean pus. We talked about how an abscess was a collection of pus that's been walled off from the rest of the body. All right, that's it for acute inflammation. Now, with chronic inflammation, remember we said that chronic inflammation usually involves macrophages, and chronic inflammation is characterized by those ongoing cycles of tissue damage and repair. Well, there's a specific pattern of chronic inflammation that I want to highlight for you, which is called granulomatous inflammation, which is where you have the formation of granulomas. What was a granuloma? We said it's a little collection of macrophages. And these macrophages make TNF-alpha, which perpetuates the inflammation and maintains the granuloma. So, one interesting clinical point is that if we give a drug that blocks TNF-alpha, which might be a drug like infliximab, which we use for certain chronic inflammatory diseases like rheumatoid arthritis and Crohn's disease, that drug is going to block the effect of TNF-alpha and is going to cause granulomas to break down. If you had latent tuberculosis, where your body had sequestered the TB mycobacteria into a granuloma in the lung, now you tear down that granuloma, what's going to happen? Well, those mycobacteria are no longer in lockdown. Now you've reactivated the patient's TB. So before you start an anti-TNF-alpha drug, you always do a PPD, a TB skin test, and make sure the patient doesn't have latent TB. So let's run down some of the more common diseases that can cause granulomas. Now, you're going to want to make sure you know this list of diseases because you may see a question where they describe a granuloma on a biopsy or they show you a photo of tissue with granulomas, and you need to be able to sort of mentally run through this checklist and see what's most likely given the clinical scenario. So you may need to write some of these down. We mentioned tuberculosis causes granulomas. But the granulomas of TB are unique because they're caseating granulomas, which means they make this cheesy type of substance. So if you see caseating granulomas, I want you to think TB. Not the only cause of caseating granulomas, but certainly the most common. Some other pulmonary diseases associated with granulomas, fungal infections can cause granulomas. So blastomycosis, histoplasmosis, that sort of thing. Sarcoidosis causes granulomas. We'll cover sarcoid in the pulmonary section of the course. Wegener's granulomatosis, of course, can cause granulomas. You can tell that by the name. Now, we're calling this disease granulomatosis with polyangiitis now. We're going to cover that in the cardiovascular section because it's a form of vasculitis that it causes granulomatous inflammation in the lung and in the kidney. And then berylliosis causes granulomas. So who gets berylliosis? Well, people who work in beryllium mines mostly. Then moving away from pulmonary diseases into a few more infectious causes of granulomas, cat scratch fever causes granulomas, which is caused by Bartonella henselae. I wish they'd rename it Ted Nugent disease. There's also listeria. There's leprosy that can cause granulomas. Syphilis can cause granulomas. Crohn's disease, it's not an infection, but it's a form of inflammatory bowel disease where you get granulomas that form in the gut. So again, if they show you an image of a granuloma, and they tell you it was found in the GI tract, they might be trying to get you to make the diagnosis of Crohn's disease. But if they tell you that the granuloma was found in the kidney, they might be steering you toward Wegener's granulomatosis. Or if they told you the granuloma was in the lung, it could be a bunch of different things. But maybe they told you the patient was a migrant worker who had been coughing up blood. That might suggest TB. So they're going to have to give you some additional clues. There's also an immunodeficiency disorder called chronic granulomatous disease, which of course can cause granulomas. We're going to talk about that in the immunology section. And finally, you can see granulomas associated with foreign bodies. Now, one of the ways that your body deals with a foreign body is to surround it, engulf it, sort of wall it off with a granuloma. So foreign bodies can cause granulomas. All right, before we go any farther, I want you to pause the video, take out a piece of paper and write down the 4 steps involved in neutrophil extravasation, and then write down the receptor molecules that we said were important for each of those steps. Let's talk about 2 important markers of inflammation, ESR and CRP. So ESR is the erythrocyte sedimentation rate, or we commonly call this the SED rate. Now this is a test that measures the rate at which the erythrocytes, or red cells, sediment, or settle down into the bottom of a test tube. So if you put blood in a test tube, inflammatory debris like fibrinogen is going to coat the red cells so that they aggregate and they clump together. And then they're going to start to settle to the bottom of the tube. You can measure the speed at which this happens, and that's your sedimentation rate. Now there's a normal rate at which this sedimentation occurs, and then in inflammatory states, there's more fibrinogen around, so it's going to happen faster, and the SED rate is higher with inflammation. Now, SED rate is extremely nonspecific. An elevated SED rate could mean almost anything: cancer, pregnancy, lupus, some low-grade infection, you fell and stubbed your toe. Lots of different things can cause an elevated ESR. Now, there are a few things that might decrease your SED rate, but that's not really terribly useful. But if you had abnormally shaped red cells, like in sickle cell disease, they might sediment out more slowly, or if you had polycythemia and too many red cells, they might sediment out more slowly. So let's take a look in your study guide question number 5, where it says elevated ESR. Again, this is just a focused, high-yield list of the potential causes of an elevated SED rate. Polymyalgia rheumatica and then temporal arteritis are both diseases where the SED rate is elevated. We often see those 2 together. You can follow SED rate to monitor disease activity in things like rheumatoid arthritis. Anytime you have infection or inflammation or malignancy, the SED rate is going to be elevated. So again, it's a very nonspecific test. There's one specific infection I want to clue you into, which is osteomyelitis. Osteomyelitis is an infection of the bone. It can be very difficult to identify sometimes. So the overlying skin may be normal. You may not see anything on the x-ray. But if you suspect osteomyelitis, one of the things you're going to do is check the ESR, and if it's elevated, that's going to increase your suspicion of osteomyelitis a little bit. Now, if SED rate's not elevated, you can probably rule out osteo right there. And then another non-specific lab test used to detect inflammation is the C-reactive protein, or CRP. This is another acute phase reactant, like SED rate, like fibrinogen, like ferritin. So what do all these tests have in common? They're all elevated whenever there's acute inflammation. Now, CRP is made in the liver, in the hepatocytes. We think it functions to help clear microbes. It acts like an opsonin, since CRP seems to bind to microbial surfaces. So whenever there's active inflammation, you might see an elevated SED rate, you might see an elevated CRP, or there might be other systemic manifestations of inflammation that affect the entire body, like fever, leukocytosis, elevated heart rate, elevated blood pressure. all sorts of things that seem to be mediated by cytokines more than anything else. But again, these are non-specific. Fever does not equal infection. Leukocytosis does not equal infection. They're suggestive signs, but there are other things that can cause fever and leukocytosis as well. All right, that's it for inflammation. So now it's time for the end of session quiz. So pause the video and answer the end of session quiz questions in your study guide, then restart the video and we'll go over the answers. All right, let's go through these questions. First one, describe the process of leukocyte extravasation. So we said there are 4 steps. There's rolling, which is mediated by selectins that select the leukocytes. Second step is tight binding, which is mediated by the integrins, they integrate. There's diapedesis, which is mediated by PCAM1. And there's migration, which is mediated by the chemotactic factors like IL-8, LTB4, C5a, and kallikrein. Next, what cytokine is particularly important in the formation of granulomas? That's TNF-alpha. Next, what cell type plays a role in inflammation by generating both fibrinogen and C-reactive protein? That's the hepatocytes. And the last question, what cell is most responsible for the acute phase of inflammation? That's the neutrophil. Remember, acute inflammation is mediated mainly by neutrophils. Chronic inflammation is mediated by monocytes and macrophages. All right, that's it for our quiz. I'll see you next time.